So today we're going to cover Module 2, which is arterial disorders. Now, arterial disorders, we can talk about either acute arterial occlusion, atherosclerosis, or then we're going to discuss a few examples of peripheral arterial disease, which is Sperger's disease, and Raynaud's disease and phenomenon. So the most common cause of peripheral vascular disease is peripheral artery disease. Peripheral artery disease is due to atherosclerosis, so the gradual process which fatty material builds up inside those arteries, similar to coronary artery disease. So over time, these plaques block, narrow, or weaken the vessel walls. Blood flow through the arteries can be restricted or completely and totally blocked, which brings us to an acute arterial occlusion. If you have a patient that has an acute arterial occlusion in their peripheral vascular system, this is an emergency 100% of the time. This is the patient not getting blood flow to one of their extremities. So a few different causes of this can either be thrombus or embolism. So a thrombus is just simply a blood clot in any artery. Very dangerous. However, an embolism is either a blood clot or some sort of piece of plaque that has flown or moved from some other place in the body, but is also occluding an arterial artery. Both instances are very dangerous and require immediate care. So manifestations, when we come upon a patient like this, there's the 5 P's. So first is pain. And I can say from personal experience, caring for these patients is very difficult. This is the kind of pain that is a 10 on a 0 to 10 scale. Very difficult pain to manage because it's ischemia. They are having no blood flow, damage to their tissue, necrosis. They feel this, and we have to give lots and lots of pain medication to these people throughout their treatment. I hate this word, poikilothemia, which it means they're unable to regulate their body temperature. So that's one other manifestation. They can't keep the warm and the cold the same. Pulselessness, I mean, it doesn't go any clearer than that. I always said this in health assessment, if you're assessing pulses peripherally and you are documenting absent, you should be doing something about it. There is no reason you should ever document absent or unable to palpate if you're not intervening. There are times where I have had to say, yes, it's absent, but maybe, we're in the process of treating that. There are ways to feel the pulses. Of course, you guys know to palpate, with your fingers lightly. And, we document bounding, 0, 1, 2, or 3. However, if you really can truly not feel them, you can get the Doppler and you can use that Doppler with a little jelly to see if there is any sort of pulse. And you want to remember where you can locate all of your pulses, pedal, posterior tibial, all throughout the, arms and legs. You know where those pulses are. Paralysis. Clear as day. They have reduced movement of that extremity. They have no blood flow, so therefore you're going to see paralysis. And then pallor is one of those most definitive ones, and you can see in the picture. They use the word demarcation, and demarcation is a word that they use to describe a clear change in color from one area to another. A lot of times you will kind of see a line of demarcation, and they'll go from maybe like red or ruddy red to like a clear, completely white. So you will see that line of demarcation. So if you are ever posed with the test question on boards or NCLEX or anywhere, and you're trying to determine if this is arterial or venous, and you see a line of demarcation, you know that it is arterial and it is an emergency. You have no blood flow if you have a line of demarcation. Okay, so you're caring for a patient with an acute arterial occlusion. What are we going to do? So first off, with diagnostics, we can do an arteriogram, or we can do arteriography. You're going to access your patient through their groin, just as you would for a cardiac cath. So they access the large artery in the groin. So when you're assessing that, you would want to be very careful and assess that groin for bleeding. So, they enter and they use dye and they look for blood flow, opening and closing throughout, and they use X-ray and take a look at opening areas and narrowed areas. So, a couple different things. If we, using emergent treatment, they can give the intra-arterial thrombolytics. Now, this is much more common than in a cardiac patient. Peripherally, it works very, very well. They can actually insert a catheter and place it exactly where the clot is, and they can infuse that thrombolytic and directly exactly where it is. So we're constantly watching these patients for increased blood flow. Literally, we're checking for pulses every 30 minutes, even more frequently sometimes with the Doppler. And we're watching for that to open. We're watching their pain to get better. These are, again, are tough patients to manage. They're also going to be on anticoagulation. We're going to give them heparin, and we'll talk about heparin, dosing and that sort of stuff a little bit more when we talk about DVT. However, we're going to have to monitor our patients' PTT and INR. We really want to watch for any sort of bleeding anywhere, and as you can imagine, you'd watch for any bloody emesis, any signs of stroke, any signs of active bleeding anywhere, would be nursing considerations. Surgery is sometimes they can do an embolectomy if they can catch this within 4 to 6 hours. So it's a procedure to remove the blood clots from the artery or graft with a balloon catheter. So they can use an embolectomy catheter to scoop that blood clot away as it passes. Sometimes it can be performed, we just want to be really careful to not agitate the clot. And while the thrombolytics are used, they can actually use this embolectomy catheter as well. Okay, so down to basics here with peripheral atherosclerosis. Atherosclerosis is the most common form of arterial disorder characterized by thickening, loss of elasticity, and calcifications. And just from experience, I know that those blockages are worst at the bifurcation. So where there's arteries joined together, that seems to be where the atherosclerosis is much worse. And unfortunately, patients do not appear with symptoms until there's a greater than 60% occlusion. Many times when I would care for these patients, they would have diffuse. When I say diffuse atherosclerosis, it means narrowed blockages throughout both of their legs. That's the most common place you'd see them is their legs. And which makes it even more difficult to manage because you've got blockages everywhere. So they can be anywhere from 60, 70, 80, 90 to 100% occluded. So some risk factors for these patients are number one, going to be smoking. Cigarette smoking really puts them at a much higher risk, along with hypertension, being diabetic, high HDL. Males have more of a predominant predisposition. Advanced stages, 60s and 70s. Sedentary lifestyle, a lot of times I will see truck drivers with coming in with peripheral atherosclerosis. They haven't gotten to move around for a long time, long periods of their life where they're driving. Those high homocysteine levels, and if you remember, that's eating lots of red meats and not a lot of vegetables. Okay, so here is an image of our leg with our with our arteries kind of mapped out for us. So the large and mid-size arteries, especially like I said, at those points of bifurcation, are very symptomatic for our patients. Also, 40 to 50, so that's about 80 to 90% are those really large arteries that you're seeing. About 40 to 50% have more diffuse arteries and more distal arteries. Sometimes you can even have patients with blockages up in their abdominal and iliac arteries. But again, like I was saying before, this is a disease that we'll see in a diffuse way. So you may see some smaller blockages down near your dorsalis pedis. You might have a large blockage up here, so you can get that, opened up maybe with TPA. But then, you've got those distal blockages too. So these are patients that many times repeat coming into the hospital many, many different times. And this is what brings those patients back into the hospital. They know that they're having problems because they have intermittent claudication. So that is burning, and it's a classic symptoms, and it can be pain, and it can be with or without activity, similar to how we discussed angina. So it's either, stable or unstable angina. So if they are having intermittent claudication, which is, pain. Maybe they're not having any activity at all, but they're having acute pain. So it's unstable. And as you can see in this fellow's toes, he's got some clear lines of demarcation right here where there is absolutely no blood flow. And then you can see he's got some necrosis on the toes. Um, so so that is what repeatedly brings them back to the hospital, is that pain. So we educate them, and we, make sure that they understand if you have that pain either with or without exercise, need to know, are you medically managing this, or do you need to come in and seek treatment? We look at those color changes, and we look at those clear lines of demarcation, but also there's something called dependent rubor. So it is color changes when we elevate the leg, it becomes pale and white. So when it's dependent, which is hanging like off the side of the bed, it becomes red. So if you were to raise this patient's leg, it would become really pale and white with position changes. So that's another thing as far as assessment goes, is if you're going to assess and document dependent rubor, then if you dangle their leg, it becomes very red. And when you raise it, it becomes very pale. And that's because of poor circulation. Also, some manifestations that your patients are going to classically look like. So those symptoms or their appearance is going to look, they're going to have thin, shiny, hairless skin, a lot of times with thickened toenails, diminished pulses. Of course, those discolored areas, if they're having occlusion, those clear line of demarcation, delayed capillary refill, peripheral neuropathy or paresthesia, so decreased sensation, impotence, and then temperature changes of the limb or extremities, so maybe cold and numb. Okay, so how can we manage these patients? How can we improve their health? So, of course, stopping smoking, avoid exposure to cold because it causes vasoconstriction. What kind of diet? Well, of course, low cholesterol, low sodium diet is going to be the best. Exercise promotes collateral vessel formation. So it's going to promote the body to develop those collateral lines of circulation to get more blood flow into those narrowed areas. If your patient's diabetic, to keep that blood sugar under control, that is going to minimize the damage done to those, to the vasculature peripherally. Positioning. We would like these patients to dangle their legs, and an easy way to just to back up just a bit with positioning, we also want to teach our patients to not cross their legs, not wear constrictive clothing, keep their feet very, very clean, use moisturizer and powder between their toes, even professional foot care like a good pedicure. No heating pad for these patients. We want to be very, very careful. They have decreased sensation. There's a high risk of them burning. Okay, so anti-platelet medications, Plavix, Brilinta, aspirin, whatever is prescribed, and that is going to, make your platelets slippery so they don't aggregate and further that clot formation. Trental is a fantastic medication. It decreases blood viscosity and increases red blood cell flexibility. It can cause some gastric distress, so we want to take this. It's prescribed 3 times a day. We want to take it with meals because it helps manage the pain in your stomach. And then the last medication is Plentol, and that is got some platelet inhibitor properties as well as vasodilating properties. So it can reduce the pain of intermittent claudication by dilating the arteries and improving the flow of blood and oxygen to the legs. It also reduces the ability of blood to clot. So enables patients with intermittent claudication to actually walk longer and faster before they develop pain. So then, of course, that's going to help them to exercise more, which would then develop more collateral circulation. Okay, so here's where we're going to determine if revascularization is indicated for your patient. So three things: they cannot perform ADLs because of pain, because of, for whatever reason, they cannot move, their mobility is limited. Clearly, gangrenous lesions are saying, your patient has necrosis and no blood flow. And then when they get to the point where they have rest pain versus pain with activity, that is an acute occlusion. And just as if your patient was having cardiac chest pain at rest, that is acute and needs to be revascularized right away. So what we can do are a few things. Non-surgical approaches are PTA, percutaneous transluminal angiography. So we can, just use or angioplasty. You can use a balloon and try to dilate those. Also, you can use a stent and place a stent just as you would in a cardiac artery. Then we have percutaneous atherectomy, which is they can remove the plaque with a catheter guide wire inserted instead of actually having to open up the vessel. There's also laser that can be used peripherally to vaporize the plaque. That's kind of the new big thing. It's a very expensive, huge piece of equipment, but it can just literally vaporize it inside of the vessel. An endarterectomy is that they remove the occlusive plaque from the artery or graft. This is an open surgery. They make an incision, open the artery, and remove that plaque. Much more dangerous because you have a higher risk for bleeding. Bypass grafting, similar to CABG, open surgery, graft bypassing the occluded area. And then worst of all, amputation. So if all other treatments fail, and it's too late and you have a gangrenous or necrotic area, you would have to have amputation for your patient. Okay, so Mr. Peripheral Arterial Disease is off to surgery. Permit reads, as you can read on the slide. So what is wrong with this permit? Well, we can't use abbreviations, RT for right. PTCA, also you cannot use those. Those are not acceptable. So you need to know, what does PTCA? Well, C is actually coronary. So, we would want to make sure that the consent reads for the appropriate area of the body. So pre-op teaching, very similar. We want to be NPO. Patient will need an IV. They'll be awake during the procedure. Have to do that pre-op checklist and cover all of the details as you guys remember learning in 361. Patient will have to lie still. Give them a little bit of sedation, but they'll have to lie still. You'll feel the dye in the balloon inflate, which causes pain, similar to cardiac pain. You're occluding that vessel distally, so they may have some pain. So you want to, of course, check for those dye allergies. You want to check for the lidocaine allergies. You want to look at their hydration status to make sure that they can tolerate the dye that you're going to be injecting. Let them know that a nurse will be in the room circulating if they need anything. They need to push fluids when they return. Maybe they might still have a line placed into their groin. Sometimes they will leave that line placed and infuse TPA or a thrombolytic directly to an area if they weren't able to get it open. So we want to watch, of course, BUN and creatinine afterwards to make sure we haven't, done anything to their kidneys. And then developing collaborative goals is huge. So you want to talk to your patients and kind of say, what is important to you to get better? And, how can we come up with ways to make you more healthy? Like maybe smaller goals, walk 10 minutes a day without pain, or change that low cholesterol diet. And then some nursing diagnosis that you might, want to consider is the patient is obviously having decreased tissue perfusion after or before surgery. After surgery, clearly going to have some knowledge deficits and changes in their health maintenance. So, ineffective health maintenance there. So there are some notes posted, in the course for both Sperger's and Raynaud's, but I'll briefly go over them. Sperger's disease is an occlusive arterial disease affecting medium to small vessels in the hands or feet. Vessels are inflamed and have vasospasm with possible thrombus formations. They may have some little bit of blood clot in there. So etiology is really unknown at this time, thought to have an autoimmune property and an inflammatory response along with that. So incidence, you're going to see this much more. Biggest risk factor is smoking or chewing tobacco. Higher incidence in 40-year-old patients of the Asian or Eastern European descent. So manifestations, it really depends on the location, but they're going to have cramping in their calves, feet, forearms, hands because of the pain that they're feeling. And as you can tell, in the picture, there's obstructed blood flow, maybe higher up in the hand, so you may see some dead tissue or beyond the area of obstruction. I've actually never seen Berger's disease myself, but what the research says is that these episodes, there's no cure, but the episodes can be more frequent and prolonged over the years. We can manage the symptoms, and we'll talk about that. We're going to manage Berger's and Raynaud's very similar ways. So Raynaud's is arterial spasming affecting cutaneous, so surface blood flow. Radial pulses are still going to be present, so this is a surface type limited blood flow. It's called the red, white, and blue disease because you'll see actual color changes in your patient's hand, especially when it's cold outside. They may have some numbness, and again, like I said, these are spasms affecting the cutaneous blood flow. So it's a phenomenon rather than a disease. So there's no identified causes, primarily affecting women in their 20s to 40s, and there is a genetic link to this. It's also linked to rheumatoid arthritis, scleroderma, or tissue injury or trauma, such as like frostbite. So the really important thing you want to know about Raynaud's is that stress and temperature changes seem to initiate attacks. Keep your patient's hands warm at all times. And if you're caring for a patient with Raynaud's, ask if cold or stress makes it worse because you will find that is a big trigger for Raynaud's. So treatment for your Berger's and your Raynaud's is going to be very, very similar. So stop smoking, reduce stress. Exercise is going to promote circulation. Calcium channel blockers are going to help relax the smooth muscle, and it's going to help with the spasm. So calcium channel blockers for both. Keep their hands warm and no exposure to cold. Avoid injury, and dependent positioning is going to increase arterial flow. So with Berger's, maybe if it is more causing damage where maybe they're having necrosis, they may need to do some arterial bypass grafting or use different medications or different procedures to keep the blood flow. So the Trental similar to peripheral occlusion. With Raynaud's, you can use the mini press or transdermal nitroglycerin because that's going to help to open those surface occlusions and dilate the arterial vasculature. So a patient is reported to have Raynaud's phenomenon. What does this mean to your nursing care? I'll let you look that one up. A patient's chart revealed a history of Berger's disease. What risk factors does the nurse anticipate that often accompany this disease? Again, I'm going to let you look that one up. Thank you.